Sure. So we are requesting the conversion of 15 limited term positions to permanent for the purpose of ongoing activities related to both our current waiver and hopefully our newly approved waiver. Really, these are all positions that are currently filled, and this work is really about doing the ongoing work, mostly in our managed care of doing monitoring and enrollment and all of those things that are important to ensure that the program is operating appropriately. You also requested that I give you a brief overview of our waiver renewal proposal. Our proposal, which we do call Medi-Cal 2020, includes a number of strategies that really build on the success that California had with our 2010 Bridge to Reform waiver. I mean, I think you all know that we've really led the nation in expansion of coverage, and we really started the national look at delivery system transformation through our First in the Nation district program. So much so that now people know what a district program is, and that's sort of a little funny to me. But so we really view this waiver renewal as really our second half of a 10-year program. The first 5 years were devoted to coverage expansion with our low-income health program, and obviously our broad expansion in 2014, 3.5 million people and growing in Medi-Cal. But what we really need to focus on now is how do we do a broad transformation of the delivery system so that we're focused on the individual, making sure that they're receiving the broad spectrum of services that they need and that they're better integrated so that they're not having to deal with different silos. In terms of our proposal, it is really focused on that, the change of our Medi-Cal delivery system, as well as for the remaining uninsured, transforming our public safety net system to continue to improve the care that's being delivered there. The key proposals really look towards paying for value and not volume. This is really consistent with Secretary Burwell's work that she's focused on with the Medicare program. We also are focused on integrating services across the spectrum, including social services and supports, and really integrating public health and social services and housing as a way, again, to really focus on the whole person and not just on the health care part of their services. And finally, we also are focused on enhancing access by looking at the different workforce options out there and looking to non-traditional providers in addition to trying to increase participation of traditional providers in the program. A lot of these, so there's about 7 different programs, and I won't go through them, but they really utilize a variety of shared savings incentives to really bring everyone together, the providers, the social services, everyone to the table and have the potential benefit of an incentive payment to drive the resources that are necessary to come to the table. Everyone is working with too little money, and so it's hard to bring all of the different silos together, and we're really hopeful that if we're able to work with CMS on this and receive the funding that we're asking, that we will have an opportunity to demonstrate that if you do it this way, at the end of the day, it actually does result in better quality of life for these individuals as well as lower cost. In terms of the process, we have submitted, as noted, at the end of March. We did have an initial walkthrough with CMS that the Secretary and I did, and we feel very positive about the support from the federal government about our package of services that we're trying to do. Obviously, at the end of the day, like many things here, the financing issues are difficult, and so we'll continue to work on that. We are expecting an initial reaction in terms of comments and questions in the next couple of weeks, and then we will start our iterative process over the next 6 months with CMS, and obviously, of course, then bringing back to the legislature and stakeholders to talk about what's happening and how do we develop in more detail the programs that are going to actually be a part of the final waiver. Hopefully it will be all of the things that we proposed, but we won't know until we start having those more in-depth discussions with CMS. So we're still tracking, and there is support from CMS that we get this done on time and have the waiver start November 1st, and there will be a lot of work ahead for us, all of you, all of our stakeholders, to make sure that this is a successful waiver renewal.
So, as my teenager would say, I don't mean to jinx the process.
Great.
But really kind of process question. What happens if CMS says no?
So it's unlikely that there will be a no. It will be a let's do something different.
Okay. All right.
So the example I give in many meetings, I'm sure Michelle's heard me say this now 10 different times, is if you actually look at our proposal that was submitted, well, ours, I wasn't actually here, but the department's proposal in July of 2010, and the new that waiver started in October of 2010, it was at least 70% different. But the funding level was the funding level, and we were still able to do the things that we needed to do, but it took that iterative process with CMS with what were their goals, we think we share the goals here, and what are their authorities that they think they can use to actually provide California what it's seeking to do.
Thank you. LAO? Finance? Senator Monning? Public comment, please, 2 minutes.
Thank you. Tam Ma with Health Access California. We support the department's request for staff positions for workload associated with the 1115 waiver and hopefully the renewal waiver that's in the pipeline. Health Access was pleased to be part of 3 of the stakeholder work groups that DHCS convened to inform the development of the waiver. We think the waiver is essential to California's ongoing implementation of the Affordable Care Act. We're very excited by some of the concepts included to make Medi-Cal more responsive to the needs of beneficiaries and to be more financially sustainable. Some of these concepts include greater flexibility for safety net funding to support primary and preventative care, and incentives to have Medi-Cal pay more for outcomes and not just per patient or per procedure visits. And we're also very excited about the concept where we work across silos of physical and behavioral health, housing, corrections, and more to address whole person care. We hope that the final waiver will move California towards not the triple aim, but the quadruple aim of better care, better health, lower cost, and reduced health disparities through both delivery system reform and population health approaches that integrate healthcare with other human services and community supports. We ask the committee to adopt the staff recommendation to fund these positions to support this work. Thank you.
Thank you. Next witness, please.
Gary Passmore with the Congress of California Seniors. We've been fortunate enough to participate in the current waiver stakeholder process and in the development of the new waiver proposal. And I would like to say publicly that I really appreciate the hard work and the effort that the department made in having broad stakeholder input. There were very few opportunities that I didn't get to express my views in this process. It wasn't the case. 5 years, well, there are people laughing because they know when I get in front of a mic, it's a trouble. But I also want to say that I am really excited at some of the original thought and new possibilities that the proposal submitted to CMS contains, and we strongly urge your support for the 9 positions that support this work that we do. Thanks.
Thank you. Next witness, please.
Kelly Brooks on behalf of the California State Association of Counties. We too were active participants in the department stakeholder process, and we must compliment them on the inclusive process and all of the work groups and the time that they put in at the staff level. I'll just remind the committee members that the waiver contains a number of important elements, not just for counties, but for county hospitals. We're very pleased to see the inclusion of a successor to the Delivery System Reform Incentive Program, affectionately known as DSRIP. That's been a crucial component to the implementation of the Affordable Care Act and to the transformation and continued improvement in our public hospital systems. We're also very pleased at the number of proposals aimed at behavioral health and the opportunities to integrate more and to have the managed care plans and county mental health plans work together and think about working together in new ways. We're a strong proponent of the whole person care pilots. It's something that has sort of generated from the counties, and we really see them as a way to improve care, but also to create some institutional relationships across different county systems, different provider networks, and health plans, and how they coordinate and provide not just health care, but social services to folks. And so we're very excited about that piece. And we have a number of counties who are very interested in the housing proposals as well. And we just are here today to lend our support generally to the waiver. Thank you.
Thank you very much. Of course, Senator Monning, please.
Thank you. And to use the words of the chair, not to jinx things, but it seems
Double jinx now.
Right, double jinx, that's right.
So the conversation between the state of California is with CMS at the federal level. And that deals with ultimately funding levels and the intricacies of delivery. Do you know, can you help me understand, what does that budget allocation, does it require congressional approval?
It does not.
Thank you.
Sure.
You've offered me great reassurance.
Because that would be a jinx. No question.
It does have to go through their Office of Management and Budget, though, which is their Department of Finance.
Yeah. It's still not Congress.
CMS doesn't have sole authority to just do whatever they want. Yes.
Okay, with that, thank you very much, and I will entertain a motion to accept the staff recommendation. Thank you very much. It's reflected on page 43. Moving on to item 9, Medi-Cal palliative care.
Sure. So this is a request for funding and one limited term position for the department to implement the provisions of SB 1004 from last year. SB 1004 requires the department to establish standards and provide technical assistance for our health plans to ensure the delivery of palliative care services. And in addition, it does require us to establish guidance on the medical conditions and prognoses that render a beneficiary eligible for palliative care services. And so this position would be used to support that work.
LAO, finance, public comment.
I move to approve as recommended.
Thank you very much, sir. We will accept the staff recommendation to approve. Item number 10, Medi-Cal, Cal MMIS.
Good afternoon, Madam Chair and members of the committee. My name is Karen Johnson, Chief Deputy Director, Department of Healthcare Services, Executive Sponsor over the CMIS. Also with me today is Vicki Sadie, Project Director. So what I want to talk about at DHCS and also as a licensed CPA, we take, the CSA, California State Auditor's report very seriously. Most of the issues that were raised in the auditor's report, those are issues that have been surfaced in our project governance system. The issue reflects changes and challenges in managing our project under the Agile methodology. So this Agile development approach is very different and unique to the state of California as well as to our department, and so our experience is limited. However, we're committed, and we are going to bring on an assessment internal expert, who can help assess the project in terms of how we're doing against this Agile approach. So the recommendations for improvement that are offered by this expert will be implemented. Also, we agree with the auditor's report that Release 2, we have been successful with the implementation of Release 1. There's 5 releases. There's about 6,000 tasks, related functionality requirements. Release 2 will be more complicated than Release 1. Release 3 will be more complicated from, Release 2, so it's going to continue to grow. So, however, as these, functional requirements increase, the ability to implement some of these level of effort to address in the new system may be complex or less complex. It just depends. So the Release 2 functionality is going to be for our child health and disability prevention program. So to the extent any issues are raised with regards to our project data, we will continue to work with control agencies and others to address this. And then in terms of the project documentation, we'll make sure that there's regular communication, that we're being transparent. And with regards to our technical architecture framework document, we did issue a corrective action plan, and we expect to receive some documents in the month of May. With regards to Health Enterprise operating in other states, we know New Hampshire, Alaska, North Dakota, Montana, and now Health Enterprise Xerox has been awarded in New York. We constantly communicate with these other states, and we actually sponsor a state user group Health Enterprise meeting to basically share out lessons learned and, based upon that information, modify and make changes so that we can be successful here in California. What is the status of the contract amendment? We are currently working on a contract amendment to align our payment provisions and milestones with the Agile software development approach. We are working through final drafting issues, and we expect that the final draft will be completed in the month of May, beginning of May. And once the final draft is complete, we will take it through our control agencies, Health and Human Services Agency, Caltech, and also the Centers for Medicaid and Medicare Services. Any questions with regards to the CAMUS?
Comment on this item? Thank you very much.
Thank you.
This is an item that we will be holding open.
Great.
Moving on to item 11, Medi-Cal Electronic Health Records Incentive Program and the issue of staffing.
Great. So the Department of Healthcare Services received approval to implement a technical assistance program to support rural solo and specialist providers in the adoption of meaningful use of electronic health record technology. So this budget change proposal requests the extension of 2 limited-term positions to initially implement the technical assistance program and funding for a consultant contract. In addition, we're also requesting the conversion of 6 limited-term positions to permanent to support and further advance the Medi-Cal EHR incentive program. To date, over $1 billion in federal incentive programs have been made to California providers through the Medi-Cal EHR incentive program. That represents over 16,000 providers and over 250 hospitals. What is the status of awarding? Final edits are being made to the document with the expectation that the final draft will be submitted to CMS next week. We expect federal approval 10 days following that. Request for application will be issued in mid-May. Awards will follow in the months of June and July. Any questions?
LAO, Finance. Any public comment on this item? Seeing none, we will accept, per the staff recommendation, we will approve this item.
Thank you.
You're very welcome. Item 12, Medi-Cal Behavioral Health Treatment, page 50.
Sure. So as noted in the agenda, the benefit began being provided by our Medi-Cal managed care plans in September of 2014. We have submitted the state plan amendment to CMS, and we are continuing our discussions with them. We are hoping for approval of the amendment by July 1st. In addition, we are looking at whether submission of waiver amendments might be necessary as well. We continue to work with stakeholders to address the comments that they've had regarding the state plan amendment, and we meet weekly with the staff from the Department of Developmental Services regarding the transition plan, which I'll talk about in a second. Our most recent April data show that about 1,070 beneficiaries are currently receiving behavioral health treatment services through our health plans. This is about a 30% increase since last month. And we continue to work on the rate development for our plans, and that includes working with DDS on the information regarding the costs that they have experienced in providing these services, as well as working with our health plans on what they are experiencing today. With respect to the transition plan, we do meet weekly, as I said, with the Department of Developmental Services regarding the transition, and we do, in our monthly stakeholder meetings, review the status of the plan. The plan will include a communication plan, reporting and monitoring requirements to ensure that every Medi-Cal beneficiary who's currently receiving BHT services through the regional center doesn't have a disruption in services when we do the transition, and make sure that as well any future beneficiaries are being appropriately referred to the health plans. We have worked with DDS to identify the Medi-Cal beneficiaries currently receiving these services who will need to transition to our managed care plans. And when the transition begins, the plans will work closely with the parents and guardians of the beneficiaries, as well as the regional center staff, to again ensure that there is not a disruption in care. And we will obviously work with our department colleagues to closely monitor this. And then finally, with respect to the question about the engagement of stakeholders in the development of the plan, we are having, I think, very open and transparent processes with our stakeholders. There was a webinar this morning. We do monthly pre-planning committees with a smaller group of stakeholders to develop the agenda for larger monthly stakeholder meetings, and again, have those every month. The standing agenda includes discussion about the development of the transition plan, so that allows time for questions and comments, and there's also a standing topic in the open forum where anyone who is participating as a member of the public, including advocates and parents and others, who can provide comments about what's going on. We do intend to present and distribute a draft of the transition plan to stakeholders at an upcoming meeting. We are targeting the May 22nd meeting for that discussion, and then we would work to incorporate any changes and suggestions from stakeholders before we would finalize a plan.
Would you please share a copy of that plan with the committee?
Of course.
That you presented, May, and also Can you tell us the number of children currently receiving behavioral health therapy services by county?
So we can look at that. There are going to be some privacy HIPAA issues, but we can
I just want
see.
numbers, not the who, but
Yeah,
numbers.
even with small number, there's some challenges, but we can see what we can provide, or, and then we can communicate and figure out what's
And
the
even if
best
it's
way.
a range, fewer than 20, I
Okay,
mean,
sure.
whatever, just to give us a sense statewide of
Okay.
kind of where the services are being provided, and give us, I think, a benchmark as we go forward with the transition, to get a sense of who was receiving the services and who is now as we go through the transition.
Yeah, absolutely.
That could be provided to the committee, I'd appreciate that. LAO, Finance, Public Comment, Behavioral Health Treatment. Are you coming to the mic? Okay, just wanted to make sure that it wasn't a, 2 minutes, please.
Good afternoon. My name is Paulina Gonzalez. I am the mother of an 11-year-old boy, Julian, and my daughter is Amelia. She is a 20-year-old college student at Mount Holyoke College. Julian is on the autism spectrum. He has many behavioral challenges and social challenges that have made it difficult for him and for us to live a normal life. Julian's meltdowns caused by routine change and sensory overload at one point escalated so severely that they were a danger to him. He began to say at the age of 10 he wanted to die, and Mommy, I don't want to live anymore. In the middle of his worst uncontrollable meltdowns, this is what he was saying. 2 years ago, the regional center suggested ABA. 1.5 years ago, they stopped paying copays. Over the period of 6 months, Julian's aggressive behaviors and meltdowns dramatically decreased because of ABA. We haven't had a meltdown where he has said he wanted to die since August of last year. We still have our challenges, but ABA has saved Julian's life. There's one problem. ABA is very expensive. My job provides private health insurance, but Julian also qualifies for Medi-Cal through institutional deeming. We have $5,000 in bills for ABA copay since September of last year. By the end of this year, the total will likely be $10,000. ABA Medi-Cal bill went into effect since September, but we will still have $10,000 in bills. We've been told both by Medi-Cal and Julian's ABA agency that Medi-Cal doesn't and won't cover copays for those that use Medi-Cal as a secondary insurance. That if and when agencies choose to vendor with Medi-Cal after the rates are determined, then we will have any new copays waived. But we'll be stuck with our previous bills, even if they were from ABA since September of last year when the bill went into effect. At this point, I may have to choose between ABA for my son or paying for my daughter's college tuition. I can't afford both. How am I supposed to choose between my two children? How am I supposed to choose between my daughter going to college, which she worked for very hard all her young life, or between my son without ABA and having to go back to severe meltdowns? I want to be a responsible American and a responsible taxpayer, but I am also a mom who loves her kids. At this point, my only choice might be to drop my son from our primary private insurance and move him to Medi-Cal so he can get the ABA he needs so that I don't have to choose between my two children. I also have to say that we as parents are confused. We don't know where to get answers as to how Medi-Cal is going to work retroactively or how it's going to work going forward. We don't know where to participate in the process. I was in the webinar this morning. I was glad to be able to be there in person. It was confusing. I had to ask an advocate about how to be on that webinar. I have sent emails to DHCS that go unanswered. Thank you.
Today in testimony, and hopefully you will get some follow-up answers with regard to the webinar process. I know that can be challenging. I'm going to ask everyone to really try to stick to the 2-minute limit request. Thank you.
Thank you. I'm Karen Fessel. I'm with the Autism Health Insurance Project. I'm also a parent of a 20-year-old on the autism spectrum. We really need that information by county because it's not clear who's getting services and where they're getting services. We have had small grants to go into 2 counties so far, and both of them had basically nobody was getting services when we went in, and now we thought we'd open some doors, and then we'll still hear that people are getting hit with let's see, they won't respond to their requests, written requests. Clients are directed to schools and regional centers. One client in San Francisco was told, we don't have a network, and then when she persisted, she was sent to San Jose. So we had to, that was like an hour away, and she doesn't even own a car, so we had to get involved in that one. We've had no speech and OT providers in the networks, and when we've gotten involved to find speech therapists, which we've done, they have not been paid for over 6 months, and this one place had like 10 people, 10 clients, and they hadn't been paid for any of them. And we were trying to impress upon them the urgency of paying, and it just wasn't happening. Many of the plans have opted not to build networks, and they're waiting till they get the rates to build the networks. And so it means that you have to take each person through case by case, person by person. It's very time consuming. We've referred many families to DHCS, and sometimes they get back to them and sometimes they don't. We have to get involved, the advocates, in order to make it happen. We don't get paid to do that.
15 seconds.
Okay. And then those in fee-for-service Medi-Cal were told that they should get ABA from their regional centers, and but then there's nothing in writing on that, and we have a client that has been denied ABA through her regional center, and they're putting her through the fair hearing process, and she's had to pay out of pocket to get an attorney.
So given all those lengthy, specific examples, I hope that you're in a position to provide those in writing to the department, that
Sure.
we're not just counting on saying it in the public hearing process, because those are
Okay.
very specific examples that I hope that they would would follow up on if you give it to them.
Okay, thank you very much.
Thank you very much. Next witness, please, 2 minutes.
Kristen Jacobson, Autism Deserves Equal Coverage. Thank you very much, Madam Chair, for allowing us this opportunity to testify. I've said this at other hearings before, but I'm going to continue to reiterate it. One of our biggest concerns is around the comprehensive diagnostic evaluation that is required for before treatment can happen. The American Academy of Pediatrics recommends beginning intensive ABA treatment as soon as a diagnosis of autism is seriously considered, rather than waiting for a definitive diagnosis. That is a direct quote. And yet, the way Department of Healthcare Services has set up the benefit, you have to get the diagnosis and comprehensive diagnosis first, and that is very unnecessarily delaying care, and it is not consistent with medical necessity standards. There are also significant delays in various parts of the state to get these diagnostics. Inland Empire has done I think it's Inland Empire, where Dr. Curry is, they've done a fantastic job setting up an entire new diagnostic center. They work with Autism Society of Los Angeles and Santa Barbara to get it together, and because they knew that they didn't have the capacity, they still have a 5-month waiting list. The requirement is 15 days to get in for an evaluation, so they're not meeting it at all. DHCS says they haven't heard any complaints specifically. However, we have just if an entire county has a 5-month waiting list, there are clearly kids who aren't getting evaluated and aren't getting served. They need to be getting treatment in the interim, like the standard of care says, until they get a comprehensive diagnostic evaluation, and then they could modify the treatment as necessary. The other thing that is really critical is this transition from the regional centers. We've had difficult transitions in the past, and there needs to be continuity of care. There needs to be not up to one year of continuity of care, because up to 1 year could include 1 day or 1 month. It needs to be 1 year at least of continuity of care for these families. They're planning on doing a warm handoff. All that's good, but if they don't have an adequate network of providers, then there isn't anything that these families are going to be able to do. We really do
15 seconds.
15 seconds. We want the county by county information. They say it's a HIPAA violation because some of the counties have so low numbers. No one's name is being released. The only people that is protecting are the counties that aren't providing that data, or the regional centers that aren't providing those services. Thank you.
Thank you. The agenda posed the question about the
realized I
long
missed the
waiting
whole
list.
2
Yeah.
pages of questions.
Okay, so let's get through the public comment, and then we
Sure, I
can
will. Sorry
fall
about
back, and particularly with regard to the waiting list issue, because that's been mentioned a couple times by members of the public. Thank you. 2 minutes, please.
Evelyn Abelhassan with Disability Rights, California Workforce Disability Organization. I just want to weigh in and reiterate the need for a thoughtful transition for these regional center clients. Also, we want to make sure that there are no unintended consequences, so that the two departments work together so that there is an adequate availability of providers, that folks don't have to pay excessive copays and deductibles, and that they get the services and the treatment that they need. So thank you very much, and if you need written comments, we're more than happy to provide those as well.
Thank you. Appreciate it.
Michelle Stoll-Parvensky, Children's Defense Fund, California, also on behalf of the Children's Health Coverage Coalition. We would align ourselves with the comments of both the autism advocates and the disability advocates, and are particularly concerned around the long wait times for the diagnostic assessments, because we think that represents a barrier to care, and there needs to be an alternative way to access those services in a timely manner. We'd also underscore the necessity of really developing a strong transition plan. Our Children's Coalition has been following ABA services and behavioral health services since the Healthy Families transition, and we know all of the problems that we had throughout that transition, partly as a result of not thoroughly thinking through all of the access problems and continuity of care problems that might show up. So we really would strongly urge the administration to work with stakeholders to ensure that that transition plan is developed. And lastly, we would love to have more detail about the DHS secret shopper monitoring that's mentioned on page 50 of the agenda, because that's something that we haven't heard about before, and would specifically be interested in how that's being done. Thank you.